All right, good evening, everybody. And I'm Paula, and I'm education coordinator for the physicians of Huntsville and South Muskoka. They're the ones that do the educating of all our residents and our medical students. And so I'm here today because part of our mandate is community engagement, is reaching out to you guys and letting you get to know some of our healthcare providers and ask questions that will make a difference in your life. So we're really glad you're here. And we're really privileged to have so many physicians in our community that are also excellent educators, and Rich is one of them. So we're lucky to have him here tonight. And they teach medical students and residents, and hopefully these students and residents will come back and practice in the North. That's our hope. And we try to give them a really nice time while they're here. And so these fireside chats, there's 4 of them this month. And next week, Dr. Pam McDermott, who is here. Hey, Pam, do you want to put up your hand? There she is. She'll be speaking, yay. And she'll be talking about end-of-life decisions. And also tomorrow I'll be sending out some evaluations on this talk, and we'd love to hear your feedback. And if you have suggestions for topics for next year, we're always looking for that. Today we are recording. Josh and Jesse are here, and you do not have to be on the video. When you ask a question, you don't have to look at the camera. They'll just have the back of your head, so they won't know who it is, okay? So you're going to be totally anonymous. And feel free to ask questions. I will have a microphone that I'll come to you if you have a question, so that your question can be on the recording, because it might be something of value that the audience will want to know. And it'll go on the MAHC YouTube channel, because the whole objective of this is to reach as many people as we can with this message, so everyone can learn about something. And then if you have any questions at all during the session, Dr. Trenholm will be glad to answer them as well. So without further ado, Dr. Rich Trenholm, it's all yours. You can introduce yourself.
Okay. Hello. So I'm Rich Trenholm, or you can call me Dr. Rich, whatever is easier for you. I do family medicine. When I first moved here in 2003 with my lovely wife, Deb Harold, I did family medicine, family medicine and obstetrics and emergency medicine. I came from a background of kinesiology, and I studied in my master's biomechanics, which is basically study of the physics of human movement. And what happened, I kind of had this always brewing in the back of my head, but I never really did anything with it. And then I came across Dr. Derek Mackesy. I don't know if any of you guys know him. Well, he's a legend around here. But in the sports medicine world, he's a legend in that world too. And so I had the pleasure of meeting him on one of my last emergency shifts, and I was treating somebody that had had a fracture, and he said, you seem to be pretty good at looking at joints and bones and stuff like that. Have you ever thought of going into sports medicine? And then I sports medicine, I didn't even know what it was. So then I started looking into it, and I went down and I hung out with him for a day a week, and then I just fell in love with it. And I forgot how much I enjoy watching people move and helping people move better and help them live well and have good quality of life and enjoy the things that they love to do for as long as they can with the freedom that their body allows. And that's sort of a philosophy that I hold in how I practice sports medicine. And I call it sports medicine, but it's really musculoskeletal medicine is the majority of what I treat and do at my job. But everybody, you guys are all athletes. If you have the ability to get up and move from point A to point B, point A being your start line, point B being the finish line, whether that's your bedroom to the bathroom, that's the race that you guys did today. So you're an athlete by virtue of that. And one of the things that really gets in the way of you moving from point A to point B is the way that the interplay of all the various movements through your body that achieve that movement. And there's thousands of bones and hundreds of muscles and lots of joints that get you from A to B. And if there's a kink in the chain somewhere along the line, that just over time wears things down, and you get a little nag, a little pain, a little catch, a little hitch, and your quality of life goes down. And then you start developing this fear of movement is what we call it. You don't move as much because you don't want to be in pain or you feel stiff. So your world, and I tell people it's kind of like a balloon, the world of your functional capacity, the ability for you to do what you want to do starts to shrink. And you stay within that bubble. But what I try to do and try to encourage people is to figure out ways on your own with the help of people like myself and physiotherapists, chiropractors, massage therapists, osteopaths, to make that bubble either shrink slower, keep it where it's at, or hopefully make it bigger. Because we want you to be out gardening, we want you out playing golf, we want you to go hiking, we want you to be able to bend down, pick up your grandkids and play with them. So I'm actually really passionate about osteoarthritis because I really want to see people have as good quality of life during their living years and be able to help them move so that they can enjoy it. So presentation today is the nuts and bolts of osteoarthritis, and it's just probably the second or third version of the presentation, because I think the first one ended up being more like a talk to medical students. And the next one was, okay, what do I really want you guys to know? And please interrupt me at any time to ask any questions, but I'm going to go through kind of the background of what osteoarthritis is, what it looks like on an x-ray, and then be able to go through some treatment options of what I talk about with people on a day-to-day basis. So without further ado, just to give you some sort of numbers. So at any given point, about 1 in 7 Canadians have osteoarthritis, and the majority is in the knee. And the reason it's the knee is because you have a hip and an ankle-foot complex that have 360 degrees of movement, or three-dimensional range of motion. But you have a joint at the knee that's a hinge. And it only likes moving forward and back. It doesn't tolerate the twist. And that's why the knee is one of the most commonly affected joints. The hand comes next because we're we need to use your hands on a daily basis. So if we have excessive loads or abnormal posturing that go through our hands, that's the next one. 19% for the hip, and the rest of the body is about 15%. It's kind of surprising that there's a really big percentage of people under the age of 65. Most people think it's something that gets you later on in life, which it does, but there's still a lot of people under the age of 65 that affects. More in common in women. Most people have pain and stiffness. And a lot of people report that they've had to change how they do things on a daily basis. And that's a number that I really want to change. 70% of people have medical conditions like diabetes, high blood pressure, cholesterol issues, heart disease. All these things increase the body's inflammatory state. And with that inflammation come enzymes that actually break down the cartilage and the soft tissues in and around the joints. And something when we are trying to regenerate our body and our body's time to fix itself is during sleep. 65% of people don't sleep well. Well, how can you fix yourself if you're not sleeping well? So dumbing it really down, what is osteoarthritis? Well, you have the mechanical overload of tissues in and around the joints. So there's the cartilage, and then there's the bones, but there's also the ligaments and the muscles and the tendons and the skin that goes around the joint that gets loaded over and over and over again with the amount of steps that we take over a day, over the year, and over your lifetime. And if we don't have well-controlled motion at those joints, then you end up getting degenerative changes to the joint tissues. And when I look at the middle circle, it's kind of like riding in a Ferrari where you don't have really good suspension, and you hear the bang, the bang. All that stuff gets borne. The extra pressures and the forces get borne by the tissues that are trying to support the joint. Whereas if you have strong, well-balanced tissues that are around the joint and inside the joint, it's kind of like riding and, I'd say my grandparents, but, my parents' Buick, just nice and cushy, that air floaty ride, right? And all of these things are compounded, meaning like the impact of it is made worse by extra weight that you carry around. I mean, weight is a gravitational pull, and that pull will have forces that go through the joint, and your joints have to experience that. Metabolic conditions, like I said, with the diabetes and the cholesterol and the high blood pressure, they increase the amount of inflammation in your body. Being inactive, so that functional bubble that gets smaller. People talk, I don't want to move, or I'm afraid to move because either it hurts or it's stiff, or I don't want to fall. And that inactivity increases the rate of osteoarthritis because there's no stimulus that you're providing to the body. And the body will change when you provide it a stimulus. If you put loads through the joints and to the muscles will be like, ooh, they need me to be a little bit stronger and a little bit more resilient. So I have to actually increase my strength and my capacity. So if you sit down and you don't do stuff, they go, well, I don't need to be making myself strong, and my nerves going to the muscles don't need to fire, and the bones don't need to be as strong. So everything kind of goes, and your functional bubble goes down. Excessive exercise. So at the far end, if you were an elite athlete and you trained a lot, and you had a high amount of loads to the joints and the tissues, that can increase your risk of osteoarthritis too. Previous injury or surgery. There's a lot of people that have had their partial meniscectomies, or some of their meniscus have been taken off because that's what they used to do. Go in, they had a little meniscal tear or something like that, and they would go in and shave a little bit off. Well, the meniscus actually is very important in controlling the forces and helping the forces get distributed evenly through the joint. So if you take that away, then other tissues have to take that load that you're applying to it, and that's often the bone and the remaining cartilage. So while a lot of people think that osteoarthritis is a matter of wear and tear, it's not. Your body is always in flux. It's making tissue, it's breaking down tissue. And what osteoarthritis is it's a shift of the balance of regenerating and building new tissue or maintaining the tissues that's there versus the degenerative process that's going on. So it's really a failure to repair, not a wear down. Like the body's trying to repair, but it can't. So this is your knee, and I kind of wanted to show you this. I don't know, is that the point? Okay, so I wanted to show you because people don't get to see inside the knee very often, and this is a really good dynamic video. And so for people, I wanted to show you is the meniscus is this yellow stuff looking at the back of your knee, or inside, you've got these horseshoe-shaped things that move as your knee moves back, and then your kneecap glides up and down in a little groove. And so the meniscus acts kind of like that shock absorbing system, and it moves as the knee moves. And this is really nice because it does show sort of the dynamic process of the knee, but it really, I guess you don't get to see the inside part of the knee that often. And the next video I have will show you sort of what happens when we have excessive wear and tear. When we're talking about arthritis, especially of the knee, we talk about what compartment is affected. So there's 3 compartments in your knee. There's the inside compartment of your knee, which is on this area, the outside compartment, or the lateral compartment, which is over here, and then your retropatellar compartment, or the behind the kneecap compartment, which is here. So most people have arthritis in the inside compartment of the knee, because what's happened, and I'll show you in a video in a couple of minutes, is people have over time developed what's called sitting disease, which has been detrimental to the strength of our feet and our hips. And so what happens is you end up having your knees rolling in like this. So if you see people that are getting up from a fall or getting up from the ground and their knees are banging together like that, a lot of the forces are going inside the knees. So you're overloading, you're overloading the inside compartment of the knee. Let me go back here. Over here. So it's supposed to be 50% and 50%, but if you're doing 80% and 20%, which side's going to wear it faster? So this is kind of a schematic of what osteoarthritis looks like, and the kneecap moving up and down. But over time, you have increased loads being applied to the bottom surface on the tibia, this bone that's on the bottom part of the knee, and you get a lot more force is going directly through the bone. The body's trying to heal bone, and the bones don't heal very fast. And so you're walking 10,000 steps a day, and so you get these miniature little breaks all the time. And so the body's trying to heal up those breaks, and you end up having the changes that you'll see on x-rays in a minute. And the same thing happens on the bottom of the femur, your thigh bone, where you get degenerative breakdown of the cartilage, and it's not as responsive, and it doesn't, it's not as cushy as it should be. So, the unfortunate part is osteoarthritis, or OA, is progressive and it's non-reversible right now. They're working on treatments that can work on reversing some of the change. But what does this really mean? Well, it means that prevention is the key. So don't get it in the first place, or wait as long as you can until you get it. And so how do you do that? Well, being physically active to a recreational or a moderate level of exercise over the course of your lifetime has actually carries the biggest amount of benefit to joint health. Not only because you're providing forces going through the joint, but the muscles that support the joint, if taking the knee, for example, you have your thighs and your hamstrings, but you also have muscles of your bum and on the inside of your thigh. They provide kind of like a nice hug around your knee, and they allow the knee to work the way the knee is supposed to work. And so by keeping them nice and strong, the knee doesn't have this jostling around and jiggling parts on the inside, wearing the joints down on the inside. Making sure that you're well from a cardiac and a metabolic point of view, minimizing high blood pressure, cholesterol, don't smoke, diabetes, keeping the sugar really well controlled. And any amount of weight loss is good. It doesn't have to be an enormous amount of weight loss, but any excess amount of weight that you carry, your knees have to deal with. And I tell people, when you're sitting here with your knees bent, your knees are experiencing 2 to 3 times your body weight in the forces that are going through it. You stand up, it's 3 to 4. You go for a walk, it's 5. And you start going upstairs, it's 6 to 7. You go for a jog, it's about 10. So, if you're a 100-pound person, or let's be realistic, 200-pound person, and you're going up the stair, or you're going for a run, your knees are experiencing 2,000 pounds of force going through it. So that's a lot for every step. So just a little bit will make a big difference. Treatments are way more effective the earlier you apply them. People often come to see me or the family doctor when they're really stiff, they're really hurting, they really can't do things. And as we get further down the progression of osteoarthritis, the less effective the tools that we can do with you, and I say with you, not to you, because you guys are largely a treatment with exercise and lifestyle issues, or interventions, not issues. But the effectiveness of each of the treatments that we can work with you guys to improve your quality of life gets less and less. So what we want to do is we want to try to enhance the existing anatomy you have: strength, stability, the nerves going to the muscles, how fast they're acting, so that when you make a sudden movement or you're walking on uneven ground, they can respond fast enough. We want to shift the balance towards restoration and regeneration rather than impaired repair. We want to minimize the amount of inflammation that your body is experiencing. And we want to control your pain, because if we can control your pain, then you're more likely to keep moving. And if you can keep moving, then the muscles will actually be able to respond the way that they're meant to be. And when you have pain control, the muscles will get stronger because they're not inhibited from your brain. They're not like, okay, it's painful, I'm going to turn off. or I'm going to dampen down how much I'm actually going to be active. So having pain control is a really good thing. Treatments should be stacked to maximize benefit. And what I mean by stacked is approaching it from many angles. You know, a lot of the times when patients go to their doctor for osteoarthritis, it's like, okay, we're going to try this first. Well, that didn't work. Let's try that next. And that didn't work. Let's go try that next. Where there's been lots of studies that support coming at it from many angles and doing many things at low doses actually has a very strong effect. So incorporating things like medications, whether it's topical or oral medications or injectable medications and supplements, stability exercise with physiotherapy or kinesiology. Tai Chi has actually got a lot of evidence for managing the functionality and pain control in osteoarthritis. Yoga, I got some braces here I'm going to talk about. Strengthening, cardiac strengthening and maintenance treatments with massage and acupuncture and mobility work. Massage has an incredible amount of positive research when it comes to managing the functionality and treatment with arthritis. So focus on functional improvements rather than just pain improvements. So when people come to see me, they often will see me for one of two things. I got a really easy job. They're either in pain or they can't do what they want to do. And when I say, okay, well, this is what's going on, this is what we're going to do, and then why don't you come back and see me in a couple of months and we'll see what's the lay of the land. We can figure what the next step is if we need to make any adjustments. Well, a lot of people will come back and say, oh, doc, my pain's no better. And I say, well, that's too bad. Well, what are you doing? Well, like it's incredible. I can go up the stairs now one at a time. I don't have to go up one step at a time. Or I can now walk down to the lake on my own, but it hurts the same amount. Well, to me, that's a win because people will always live at or close to the threshold of their pain in order to regain their functional capacity and their activities and their quality of life. So I tell them, well, you can have one of two things. You can either stay doing what you're doing and the pain go down, or you can increase the amount of functional capacity and functional endurance and quality of life, and your pain will stay about the same. Ideally, as you get closer to your functional ceiling, the pain starts to go down. So and once I sort of tell people, and I hear a couple of people say,
Oh, we said that loudly.
Yeah. Yeah. And that is true. And they're like, oh, yeah, okay, I guess I am getting better. And I'll keep going, okay? So really focus on functional improvements rather than pain improvements at the start. So this is another thing that people come and see. They come in, have you looked at my MRI? Have you looked at my x-ray? Have you looked at my ultrasound? And I'd say no, because I don't want to look at them. And I always, so I say, well, what we see is not always what you've got. So I always take a good history to find out, what you can do, what you can't do, what gives you pain, where's the pain, how much pain, what's your sleep like. And then I do a physical exam. And then I order tests if I need to, or then I look at the test, because if the tests don't support what I'm finding through my history and through my physical exam, then that's not the problem. There's been lots of studies, x-rays, MRIs, CAT scan studies that actually looked at people with a joint that is sore on one side and not on the other. And there was actually more pathology on the asymptomatic side than on the symptomatic side. So you can't take the context of what I see as virtue of what's going on. You have to take into context of what's the pain. And and that's the last point here. There's a strong dissociation between radiographic findings and clinical symptoms, and only 40% of patients with moderate radiographic or X-ray knee arthritis, and 60% of those with severe findings have symptoms. So the benefit that I have, and this is why I pull up X-rays when people come and see me in the clinic, I pull up the x-rays because I have my patient sitting right beside me. The radiologist is not sitting right beside you when they're looking at your x-rays in a dark room. So when you go see your primary care provider, and they give you the report doesn't necessarily mean that's what's going on. So ask, can we look at my x-rays? Is there a way that we can do that? Yeah, we can all of us can log in. But I mean, I'm not your primary care provider, but that's the kind of discussion that I have with people that come and see me. So here is your knee x-ray. And so very important part when somebody is getting an x-ray. How many people here have had knee x-rays? How many of you have, no, keep your hands up, okay? How many of you have had knee x-rays while you were standing? Oh, you had 2, you did it twice. So that's really important. A lot of doctors don't necessarily do that because the x-rays that you get, you're actually lying on a table, and well, you don't walk around lying on a table. So we have to have you standing up. We have to have weight going through the joints to assess it. And so this is relatively normal, maybe a little early arthritis, but here's that inside compartment, there's the outside compartment. And this is not the view to look at behind the kneecaps, but this gives you a sense of what I look for. So these are where things start to break down. And if you look at this is standing. And which knee do you think is the symptomatic knee? The right knee or the left knee? So this one's the right, and that's the left. How many say the right knee is the symptomatic knee? You guys think this is a trick question. How many say it's the left knee? Yeah, so the left knee is the symptomatic one. Where this looks way worse. Because you look here, and you can see how this part of the knee looks whiter, and whiter means more dense bone. And a bone gets more dense when it has been exposed to higher forces over the course of a period of time. The body is trying to build up more bone to take the pressure that it's being exposed to because the cartilage isn't doing it. You actually have these, it's not a great demonstration of it, but you have little pockets of bone off to the side here, and those are called osteophytes. And the osteophytes are the body's abnormal response to build new bone in the direction of where the force is going. So if the forces are going down this way, the body's trying to actually grow the joint out this way. And you can see that there's a big discordance in the joint space between the two sides. You often will see these little peaked parts on the inside of the knee, and that's where the two, they're called cruciate ligaments. They're crisscross ligaments on the inside, and they get peaked because there's too much forward and back motion of the knee, and so the ligament inside the knee actually starts to turn into bone as a way of dealing with the amount of forces that they're being exposed to. We look at here, this is on the left knee. You can see all this extra white bone that's being developed along the tendon of the quadricep muscle up here. And you can see it's almost bone, like really bone on bone inside the left or behind the left kneecap. And this is an x-ray that's taken with you having your knee bent and it's shooting down through your knee that way. We call it the skyline view. So I was fortunate looking back through my x-rays. This shows you progression over time. So this is the same patient who had standing views in 2016 and 2024. And you can see that the changes aren't actually super different, but you can certainly see that the joint space on the inside is less. You can see how the bone is more dense. You've got a little bit of this knobbly stuff over here. And more so on the left knee, you've got this, you have reduced joint space, you've got increased density of the bone around the surface. And the whole lateral compartment, or the outside part of your knee, is widening up because a lot of the forces are going down through the inside part of your knee. This is another patient that I saw actually yesterday. And this is a really long time, so 2009 to 2024. I don't have the left knee, But you can see this is where that joint is extending out this way. You can see the little knobs, and you can see that peaking of the spines is a little bit more prominent on this one. And you do get this flattening of the bone compared to this nice scoop. So, and like I said before, a little does a lot when it comes to weight loss. And when I talk to people about weight loss, I talk about sustainable weight loss. And to me, sustainable weight loss is about 0.25% per month. And meaningful weight loss that has resulted in clinically significant improvements in joint health function and pain has been measured over 22 months, so just shy of 2 years. So, while people are looking for that, I need to lose 20 or 30 pounds now, or do it in a couple of months, it's not sustainable. And it doesn't actually mean that in the long run, that's going to result in clinically significant improvements in your pain and stiffness and functionality. So, the excess weight that you carry around not only applies to the forces that go through it. Adipose tissue or fat tissue actually secretes these chemical compounds that accelerate the natural process of breaking down the cartilage. So, while it's great to lose weight, it's trying to lose the weight because of the fat. Fat cells has a really big impact on the things that are beyond just forces going through your knee or any of the joints. Get moving and keep moving. The effect of strength, stability, and exercise. The benefits of exercise when it comes to osteoarthritis is usually at around a 6 or a 9 month window. When I talk to people and I come up with a treatment plan, I often say I'll see you back in about 8 weeks, because that's when we're going to start to notice some effect. And I want you to keep with it up until that point. And they'll be like, when they come back, they'll be like, yeah, I really didn't believe you for the first 6 weeks. But that's when I started to notice that, I was being able to change the way I was doing things. So be patient, be consistent, and be progressive is what I tell people. Progressive meaning do more, make it more challenging, make it harder, go further, wear a backpack with a couple of cans of soup in it. I don't care. Just challenge your body. If you challenge your body will respond. And it reduces the fear of movement factor. You start moving, you'd be like, hey, I can do this. This is pretty good. And it might be that I just was able to walk from the couch to the bathroom, but now I can go to the couch to the kitchen to the bathroom. Like that's pretty good. And so the exercise improves the health of the cartilage. It reduces the inflammation and it shifts that balance from degradation to regeneration. So this is a video of a test that I do with patients. And it's called a standing squat, and it tests everything from your nipples down, basically. It's really good for testing your core strength. And what I really look for is this, I call it dynamic internal rotation. So when she starts to squat, whenever she wants to squat, hello, okay, let me go back here, okay? And you can sort of see how her knees want to buckle into the side, and she's shifting her weight off to the left-hand side, and her knees are bent onto the inside. See how she's sort of shifting her weight, and her knees are like, oh my God, I can't hang on. This is just trying to bend down a little bit, okay? And I'm no picture of health either, but this is just what I'm trying to demonstrate is, it's the control of that rotation to sit down and stand back up. And we sit down and we stand up how many times a day? Hundreds of times a day, right? But it's being able to control that movement. So then I say, okay, I'm going to make things a little bit more interesting for you. And let's do it on one leg. Because when you're walking, it's a series of stepping on one legs. Okay, so you have to do it. And she's trying to maintain stance on that one leg. And you see how far she's leaning to the side like this? Well, we're meant to stand out like this. And your center of gravity is here, and it's going off to the inside of your foot. You need the muscles around your hip and you need the muscles of your feet to control that movement. But if you want to turn those muscles off, you lean over that. Or, oh, there we go. And so, even though most of our problem is the pain in the knee, you see how hard the foot's working to control the rotation of the limb? That's why we concentrate so much on making sure that people have strong feet. The feet and the hips work together. If the hips, which control a lot of this movement, can't control that movement, then the foot has to do the micro adjustments to keep it within that range. So they work together to make sure your knee is straight. So it doesn't have to be complicated. So what I want you all to do, stand up, please. I'm going to borrow this chair. And we're going to do this little video. Yay. So one of the things that if somebody's waiting for physiotherapy or for kinesiology or some sort of strength training, I say, all I want you to do is I want you to go find a chair and put it somewhere you walk past a lot. Could be walking past the kitchen, walking to the bathroom. And all I want you to do is I want you to try to nice and slowly sit down. Don't sit down, just touch your bum to the chair and then stand back up. Okay? Okay? Nice and slow. Okay? That's it. And then walk on. So do it once. You'll probably do 50 squats over the course of the day. The key with this, and I'm seeing a lot of you guys, the key with this is to not, how that lady was leaning like this? For the squat, the same thing. If you lean far forward, you're moving your center of gravity over your feet. So try to stay as tall as you can. Okay? It's hard. Yeah. And if people come and they say, I can't do that, it's too hard, I say, well, then pick a higher seat. Put a pillow on the chair and just touch your bum to the pillow. And eventually take that pillow away. And when it gets too easy to do one at a time, then do two at a time. The other thing I tell people to do is walk up the stairs mindfully. So don't just go bump, 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 up. Put the foot on, okay? And take a step, load that leg, push yourself up. Because really what it is it's a bunch of single leg squats going up the stairs. So incorporating it into your day is just making it easy. You don't have to get your spandex on and put music on. It's just you go up the stairs, make sure you make it a strength exercise. And if you can't go up the stairs and it's too hard, then step on a book. Push up, go across, and step down. That's it. And if you got a little step stool, you can do that.
Should you exercise through pain?
Here's what I tell people. I say exercising through pain is okay as long as it's no more than 4 out of 10 on 0 being no pain, 10 being the worst pain you can imagine. And I use the next day noon rule. If you're in pain by next day at noon or stiffness, then you probably did a little bit too much the day before. So does it mean stop and don't do anything anymore? No. It means dial it back a little bit, keep going, and eventually that pain threshold will move up, and then you'll be able to progress. Yes, sir.
Throughout your presentation so far, you haven't mentioned anything about painkillers
Yeah.
or medication.
Yeah.
Is that on purpose?
Yeah. Yeah. Because it's coming. Yeah. So yes, it's coming, but for the treatment of osteoarthritis, everything I've talked about up till now is actually going to be more effective than any shot or pill that we can give you. A pill, a cream, a shot, anything like that will help you control the symptoms to be able to move. But at the end is what do we want you to do? We want you to move. okay? It's there to help. And that's one of the caveats, and I'll say it now. I don't know if the drugs are coming. Okay, yeah, they're coming. But one of the caveats I tell people when I'm doing an injection, and whether it's a steroid shot or the viscosupplementation shot, or I'm going to give you some naproxen or meloxicam or any pills, I say, I'm giving this so you can have better pain, so you can do the exercises that I really want you to do. So it enables you to be able to do the treatment that actually works. Yes, ma'am.
Why don't our doctors offer some of those medications you're talking about?
Good question. I would ask them yourselves. That would be number one. They're expensive. Some of them are expensive. Some of them aren't super expensive. But when I look at and when I explain it to patients, it's kind of like if your car's muffler was dragging on the ground. Oh, yeah. If your car's muffler was dragging on the ground, you'd probably take it to the shop and get it fixed, right? It's going to cost you a couple of $100, and then you can drive it. Well, these shots are going to be a couple of $100, but you're driving in your car every day, 24 hours a day. And if your muffler is dragging on the ground and you can't drive your body the way you want it to drive, then where's your quality of life? Yes, ma'am.
You mentioned
Oh,
that,
we got questions.
you mentioned that an excess of weight
Yep.
is not great.
Yep.
So why would you put soup cans? Why would you put soup cans in your backpack?
Haha. So it's a balance between the exercises to stimulate, and exercises are only as good as the amount that you stimulate the body. So if you've got a lot of weight and you're having symptoms, then we have to do a bit of a shift. Take the excess adipose tissue or fat tissue off to whatever degree you can, but the soup cans to stimulate not only the joints, but the muscles around the joints to become stronger so they can support the joints. So you're going to start off the exercises without the soup cans, but then as you get stronger, you need to challenge your body a bit more. So if you went into a gym and you did 10 push-ups, and then you did 10 push-ups every day for the next 5 years, your body's going to say, well, I can do that. I don't need to get any stronger. You have to challenge your body. And by putting soup cans in or hanging on to a grocery bag with a couple of soup cans, if you're doing the sit-down thing, you're challenging your body to become stronger. Yes, ma'am. Oh, we're going to do the microphone thing.
You've mentioned how much work the feet had to do when she was doing the squatting.
Yeah.
What is your opinion on footwear and the level of padding and sole support and cushion support and shock absorption that we currently have in our shoe wear, whether it's athletic shoes or regular shoes, and that contributing to the weakness of muscles of the feet?
It's a good question. If you have shoes that have a lot of padding, it's actually challenging for your feet because you're now walking on an uneven surface inside your shoe. So your muscles of your feet actually have to work pretty hard to maintain the ability for your foot not to be wobbling everywhere with the shoes. The people that I see having problems with their feet are people who wear and have worn over the course of their life shoes that feet have had to fit in. So tapered shoes, when you look at your foot, it's not tapered, it's supposed to be out like this. So finding shoes, when people are saying, well, what kind of shoes should I buy? I tell people, well, find a shoe that you can wiggle your toes in and you're really maybe touching the sides. You don't feel like your toes are crammed in there. And your foot should fit the shoe. The shoe should not, the shoe should fit your foot. Your foot shouldn't fit the shoe. So we see a lot of people with arthritis in the high-heeled shoes because all the pressure is going onto a very small surface at the front. They're really, really, really tapered. people who work downtown Toronto and they had all the fancy like leather pointy shoes. Those are the people that we're seeing now. And, it's a bit of an extreme example, but it's kind of like a modern version of Chinese foot binding. There's no way that you can possibly, the muscles of your feet have a chance to work if they're crammed into a shoe. It's like, again, going to the gym, I'm going to go do bicep curls like this. It doesn't work. You need the muscles to have the freedom to move, to control the joints, to move and act like a foot.
So would you recommend the running shoes, or would you recommend those shoes that they have that kind of look like socks?
The fingers, well,
Yeah.
I want you to have a shoe that makes your foot feel like a foot. And if that's a shoe that the Vibram 5 fingers, great. If it's a shoe that is like what you're wearing and you can move your toes in there, great. So I don't particularly, there's a couple of running shoe brands that I like, but it's, my foot is different than your foot. And whatever you feel like a foot, your foot feels like a foot inside the shoe. Kinda, sorta? You're looking at me skeptically. We can talk after more if you like.
I have a question.
Yeah.
Okay, I have it in my feet and my hands,
Mm-hmm.
but I don't think it's caused by wearing tight shoes because I've never wore tight shoes any time in my life. So osteoarthritis is not necessarily due to an overuse or an underuse of your muscles or tendons or stuff. Is it?
It's multifactorial. I can't, genetics also has a part to play with it. The metabolism in your body and the amount of inflammation that your body has experienced over the course of your life. If you've stubbed your toes many times, that will do it. If you've broken your foot, that will do it. So there's a number of factors. Especially with the hands, how manual and repetitively manual did you do tasks? That's where people often have issues in their hands. If people come with bunions, bunions are largely caused by the narrow footwear over years. And, when I say years, I'm talking 10, 20 years of being jammed into shoes. And they can be corrected, but again, it takes a long time to correct them by encouraging the toe to go back in line where it's supposed to. Yeah. Yes, sir.
Rich, often when we're at home, we're tempted to just walk around in bare feet or sock feet.
Yeah.
You got any comments about just being at home and lounging like that, or when we're walking like that? Should we have support on our feet, or is it okay to be walking in bare feet or sock feet?
Love it. I love it. Anything that gets your foot to engage with the floor, and it has to go from a floppy structure to creating what we call a rigid foot, to accept the forces of your body interacting with the ground and then returning that energy into the floor, is great. So walking barefoot is fantastic. Yeah. The more support your foot has, the less ability your foot has to be a foot. I spend more time de-prescribing orthotics than I do prescribe orthotics. Orthotics is like a cast for your arm when you broke your arm. I don't know if people have broken their arm or know people have broken their arm. They take the cast off and you got this super skinny arm. Well, if you've had a cast on your foot that's prevented your foot from moving because you've got this rigid structure, then what's going to happen is the muscles will be like, well, I don't need to do anything. I got this thing doing it for me. And then you take it away, and then the muscles of your feet don't know what to do. And so you can't just take the orthotics away. You have to sort of transition off of it over several months, because that's all your feet know. Yeah. Yes, ma'am.
What about the nutrition in what you eat, toxic food and sugar and all that stuff?
Yeah, I think a lot of that, a lot of the dietary elements lead to a pro-inflammatory state in your body. So, sugars and carbohydrates, and you know, there's people have inflammatory responses to dairy, and there's a lot of new information coming out about, you know, gut health and the microbiomes in the gut, and, you know, all of that managing our inflammation throughout the body. And it's got a lot of validity. I don't think it's been studied super well in the arthritis world, but, you know, if you can extrapolate and think of, okay, well, we've got, you know, all these metabolic disorders that cause a pro-inflammatory state, or like an enhanced inflammatory state inside the joints. Anything to minimize the inflammation as much as you can is great. I'm going to go over to Steve, and then we'll come back to you. How's that? Okay? Yes, sir.
Thank you so much. So far, you've been talking about knees and hips especially.
Yeah.
But I was going to ask you, how much should we take about lower back issues, which we certainly have seen in our own family, and whether that's a specific issue that you would, or maybe you're going to address anyway, but are some of the things you're saying quite the characteristics that could be carried right through to the
100%.
maintenance of the back?
Yeah. I mean, you could have arthritis, what we call end plate arthritis, of where you have the discs in between the vertebrae, or there's these little facet joints on the back of the spine. You know, arthritis is arthritis at the end of the day, and, you know, again, managing the weight, keeping the muscles around those joints nice and strong and mobile, you know, keeping you know, excessive weight off, minimizing inflammation however you can, keeping those joints working like joints. That it's, you know, it applies to the knee, it applies to the hip, it applies to your neck or your low back.
Not really a question, but just to feed on the mentioning of nutrition, and you said it hasn't been studied very well. Being a nutritionist myself, and in my own practice, it's been studied very well, and I can tell you that nutrition is the fundamental of any inflammatory condition, which any arthritis, and in this case, osteoarthritis is. And we've mentioned a lot of kind of causal factors, and that's way downstream.
Oh yeah.
Inflammation is way downstream of what really causes these kinds of things. And we have to go upstream of that, and upstream of that is nutrition and lifestyle. So that is your exercise, and yes, nutrition, that's what will drive your inflammation. That's what will drive obesity, that's what will drive cardiovascular diseases, that's what will drive sleep, you know, that's what will drive everything. So yes, definitely nutrition is one of the fundamentals that causes or prevents this.
Yeah, I wouldn't say that. I wouldn't say it's not important. It is super important, because, you know, why do people have cardiovascular or metabolic disorders as well? It's, you know, genetics and nutrition and physical activity. It's the fundamental blocks of it. You know, and the impacts of it haven't been, you know, in the scientific literature, that it hasn't been as studied as well as, you know, drug company stuff, because that's where the drug companies like to spend their money to investigate. But if you go looking for these kinds of lifestyle modification, and the exercise studies, like an exercise study and the impact on arthritis is not a sexy study to a drug company or anything like that, but, you know, they're out there. And the same thing with nutrition. If there's ways to minimize inflammation through diet, and again, it's a multifactorial thing. You hit it from many angles. It can't be just like, okay, I'm going to do this or I'm going to do that. Yeah.
Does vitamin C and vitamin and calcium help bone reconstruction?
Vitamin D and calcium, they do. Yep. It doesn't necessarily have a huge impact on osteoarthritis. You know, from supplements, the supplements that I would say have had some clinically important findings have been glucosamine and chondroitin when taken together, and it only helps about 30% of people that take it. And so I have a bit of a 3-month trial window. So if you take it for 3 months and you get a benefit from it, then keep taking it. If you don't, then stop taking it. Curcumin and turmeric as a natural anti-inflammatory. Omega-3 fatty acids, they work alongside of the physical activity and some of the other supplements in order to reduce inflammation and maintain bone and joint health. So those would be, if I had to look at the studies that were out there that what I could say would have some effect, those would be the ones that I would say.
You said vitamin D and calcium.
Yeah, that's more for the osteoporosis.
Is that D3?
Yeah, that's
Or
preparation.
NAD?
NAD, yeah, it's usually D3 though. Yeah. Hi. Oh boy.
What are your thoughts on the keto diet for reducing inflammation? And is it a good idea?
I think, keto diet, it's a hard diet to maintain. Will it work to help with weight management and getting weight off? Yes. Is it sustainable? Does it provide you with that sustainable weight loss? I think there's very few that can maintain that diet. I don't know honestly much about it with respect to an anti-inflammatory component, so I can't comment. Sorry.
Keto diet is very anti-inflammatory, but it has a lot of caveats where it can be harmful if not done properly. It's not something that you should be doing for a prolonged period of time, regardless. But yeah, it's a complicated diet, and it cannot be answered in one sentence, yes or no.
No.
Are you pro or con as far as surgery is concerned for repairing arthritis?
Well, I'm pro if conservative has failed. And conservative being this stuff, and I haven't even gotten to the medications. So if you can bear with me for a couple of minutes, I'd like to talk quickly through, what, physicians can offer, from the injection and the pills and creams and all that stuff. So I'm gonna fly through that, okay? Okay. Bracing is something that's not often approached, and there's specific braces, and we have a couple here, and Bruce in the orange shirt has one on. These are very fancy custom braces, and they're not cheap, but they help take the load off of an inside compartment of your knee, and almost immediately from the moment you put it on, it helps because it physically is providing additional strength on the outside. So if anybody wants to see these, you come up and talk to me afterwards. But it acts as what we call an exoskeleton. So it's like enhancing the bony structure and the muscular structure around the knee, thereby immediately providing you with the strength and stability. There's lesser models that aren't as expensive, but they're pretty effective. But again, these kinds of things, and they have rigid side bars. Those are the things that work well earlier on in the course of arthritis. These ones are more effective later on. Okay, and as you build, this is a transitional thing too. Like as you become stronger through the exercise, you can rely on these less. So, can I use you as an example? So Russ, back corner, good friend, he came and he wore one of these braces because of his knee arthritis, and he's needing to wear it less and less, and he just wears it when he plays hockey, and he goes for a run now because he's built up the muscles to do what he needs to do over the course of the day. But when he needs a little help from a friend, he puts it on. Okay, so most people, when they go to their doctor, the first thing they will get is a prescription for an anti-inflammatory. They're the most commonly prescribed things. People often use just Tylenol, or they don't want to, they alternate between Tylenol and Advil. They don't want to take both at the same time, and I don't understand, because they are two totally different medications. You can use them together. They're better when used together than whenever they're used on their own. So, if you are somebody that wants if you're on an anti-inflammatory, there's no harm. You're not going to overdose. You're not going to kill your liver or your kidneys by taking Tylenol. You'll do that if you take too much of anything, but if you take appropriate doses that are on the bottles, you'll be fine. Oral anti-inflammatories, you run the risk of stomach irritation, ulcers. Your blood pressure can go up over time. In some people, it can affect their kidneys. There's a classification that most of us use called COX-2 anti-inflammatories, and they're easier on your stomach, but it still has the effect on your blood pressure and your kidneys.
What about Celebrex?
Celebrex is a COX-2. Yeah, so it's that kind there. So topical therapies, a lot of people go to the store and they find Voltaren and they put it on, and they put it on a couple times, and they say, oh, this doesn't work, it doesn't work. Well, the reason that it doesn't work is because it has very shallow penetration. Most topical creams only penetrate about 4 millimeters underneath the skin. The thing that most people don't know about is they're actually over time more effective than oral anti-inflammatories, because what happens is it is actually lipophilic, meaning it likes living in fat tissue, which is the skin and the fat underneath the skin. And so if you put it on regularly, then your joint starts to get bathed in the anti-inflammatory effect. Okay, so if you're going to use it regularly. Don't expect a magic, snake oil to get rubbed on and it feel good after one rub. There are prescription strength creams that are stronger, that we can compound up. They are more expensive, but they're also more effective because the doses that accumulate in the tissues are higher. And it's good if you just have one area, your hands or your knee, that's affected. I tell people, why are you taking a pill here, having it fly around your whole body for almost about only 20% of the actual med getting where it's supposed to go? That's the reality of a pill that you're taking orally. Only 20% is going to get to your joint. So do I give people the option of using a topical? Yes, if it's one joint and if they're going to use it regularly. So visco supplementation is a great medication that we can inject into joints. And what it is it's hyaluronic acid, and hyaluronic acid is the compound that is a part of the synovial fluid, which is the lubricating fluid inside your joint that reduces joint friction. It also works to reduce inflammation inside the joint that is being injected. It does take a while for the lubricating gel to work, and because it's a thick gel, most people think it's in there and it stays in there for months and months and months, because it's like hand cream that we're putting in there. But it actually only stays in the joint for about 2 or 3 days before the body processes it and goes away. But that time that's in there bathing the joint for 2 to 3 days, it goes in and it reduces inflammation, it modulates the proteins and the enzymes that are inside the joint, and it goes into the cells that make the slippery fluid and it wakes them up. And it makes those cells make more of the naturally occurring synovial fluid, or the slippery fluid. And that's why this medication is much more effective if we use it earlier on. If we give it in early, like mild to moderate arthritis, it has a 90 to 95% chance of success of it working, as long as the injection's going in where you're putting it, or where you think you're putting it, okay? As it gets further along, it gets less and less, down to the point if you've got moderate to severe arthritis, you're looking at a 50 to 60% chance of it actually doing anything. And it's not cheap. These shots are anywhere between $350 to $400. It's not like a steroid where you have to wait 3 months between the shots, but you can use this anytime. You can do one again in a month if you wanted to. But often we couple this with a steroid, because a steroid shot only lasts 4 to 6 weeks. And so we put the steroid in to cover that early period of time while that medication's building. So we stack that treatment inside the joint. And the research that is out there, it's not a cure-all. What it does is it delays surgery by about 2 to 3 years. So like I was talking about there, the steroid, it's a short-term relief. It's about 4 to 6 weeks. And the only thing it does is it helps with the pain. It doesn't go in and stimulate the joint to make more of the slippery fluid. If you give it too much, it actually can accelerate that degenerative process, because it goes in there and impairs the regenerative process if given too much. And that's why doctors will only give it every 3 months, and they'll only give you a couple of these shots. One risk that is not often talked about is this risk of avascular necrosis of the femoral head, which is a serious complication where the blood flow to your hip bone is interrupted by the medication, even if it's given in your foot. It's very rare, but it can happen, and it's a quite serious complication that will lead to a hip replacement. You can give steroids at any stage of arthritis. It's like putting 1,000 Advils right where it counts. That's what I tell people. And we can't give it leading up to surgery, because it can impair the bone's ability to heal itself. So if I give a shot of steroid and you go for a joint replacement, and we've put the metal components in there, then what's going to happen is the metal components aren't going to be able to be integrated into the bony tissue. So we have to be careful with the timing. The last, I think this is the last classification of medication I'll talk about. It's called PRP, or platelet-rich plasma. It's becoming, it's still early on in the days of it being studied. It's a treatment where we actually take a sample of your own blood, we put it through a centrifuge and spin it down, and we actually just take off the platelet part of your blood, and we inject that into the joint. And it's got a lot of growth factors and a lot of regenerative enzymes and proteins in it that actually can delay surgery by about 4 to 6 years. So it's much better than viscosupplementation. It stimulates cartilage cell development, and it shifts even more that balance from degeneration to regeneration. It's crazy expensive though. Some drug plans cover it, some don't. It's about $700 a shot. I don't do it because it's really expensive, and I haven't really. I have to wrap my head around it because it is so early. If it's going to be something that is going to be that expensive, I got to know that it's going to work, and I bet you guys do too. So I do things now using an ultrasound guidance plan, and so this is me doing an injection of the knee under ultrasound guidance. So this is like putting it where it counts. I know where the needle is, and I'm putting it in the right spot. Yes, ma'am.
I had injections put in both my knees last summer.
Yeah.
And it was really painful getting in. I felt like it was going into the bones.
Did I do it?
No.
Okay.
I wish. I felt like it helped for the first few days.
Yeah.
But I still had pain off and on.
Okay. Do you know what the shot was? Was it steroid or was it a really expensive shot?
It must have been the steroid.
Yeah, like $20 or $30 or something like that?
I didn't have to
Pay for it? Okay. So it's not uncommon when you do get a joint injection that there is a flare of the symptoms for a couple of days. So when I do an injection in somebody's joint, I tell them, I want you to take it easy, get treated like a king or a queen for a couple of days, do what you have to do, but don't do any more than you have to. Because we want the medication to work. There is this little bump of sort of a joint inflammation and reaction that happens. And so we just need to be nice to your knees for a couple of days so the medication can do what we want it to do.
Yeah, because at the time I had a Baker's cyst behind one.
Yeah.
And they were both bad, so I got them in both. But the first drug that you mentioned, do you know if that's covered for seniors?
The viscosupplementation shot? No, it's not. It's not part of the Ontario Drug Plan. So there's a myriad of these injections on the market. Head-to-head studies really show that there's not much of a difference between the kinds. My conflict of interest is that I am one of the owners of Reactivate, but I carry two at my clinic, and one's a cheaper version, and it works just as well as the more expensive version. So I don't actually I don't use the more expensive one a lot because the cheaper one works for more people, and I'd rather more people have access to it.
So if we wanted you to do it, do we have to get a recommendation from our doctor?
Yeah. You need a referral to come and see me to get an injection. For me to do an injection, and I do an injection clinic once a month where a doctor can send a referral, and it's just like, I just want you to inject this person's knee, and I won't do a full history and assessment, and like I'm just a technician, because most of my consults, all of my consults are 45 minutes to 60 minutes to go through your history and physical and treat and educate and all that stuff. So, this is a 15 to 20 minute appointment to look at your images and read your story and take a quick history and then do the injection. So,
Okay.
Yep. Yes, sir.
You mentioned turmeric.
Turmeric, yeah.
Yeah. I've been using it for years.
Yeah.
Every morning I have a turmeric cocktail.
Perfect.
I was just wondering what effects, bad or good.
Well, I think, turmeric usually, again, it goes back to if it works for you, then it works for you. Some people it doesn't work for. People take it in tea. They take actual teaspoon of turmeric. They take turmeric tablets. It's about 1,000 to 1,500 milligrams of turmeric that you need. That's what all the studies have been done on. But yeah, if you respond to it,
Good.
do it. Yes, ma'am. Oh, yeah.
The Arthritis Society
Yes.
is excellent.
Yes, they are.
They have been putting on a number of videos. Obviously, you need internet for it.
Yep.
They've done one on diet.
Yep.
They've done one on exercise. They've done one on sleep
Yeah.
and medication.
Yeah.
Continuing, and they are really worth watching.
Yeah, the Arthritis Society. Yeah, their videos they're very good. Yeah. Yes, sir.
Rich, just if testimonials are happening here, we did the Synvisc with me 16 months ago. It's completely changed my life.
Yeah.
I'm walking 3 times as much. I haven't had pain in my knee. I have weakness in the knee, but I have not had pain. And I'm walking an average of 135 kilometers a month.
Wow.
And on an ongoing basis. And I'm a strong supporter of what you're advocating.
Good. And that, I think that, thank you for that. And that speaks volumes to, we gave you the ability to be active by, using a medication or an injection. And one that lasts longer than the 4 to 6 week steroid shot that a lot of people get, because then you can get into that routine and then you can build up the cardiovascular endurance, the strength endurance. I mean, you come in the clinic and you get on the recumbent bike and you pedal away, and it is amazing. I love seeing people like you and hearing stories like this. I can now go and play with my grandkids at the playground. Great grandkids,
The 35-year-olds are too heavy to lift.
You have a question here?
Oh, yeah.
I've been looking at this slide and it really hurts my knee.
I'll switch off.
I've never had that done. I don't think I will either.
Yeah.
Is there anything you can do so that it doesn't hurt
Yes.
that much?
Yeah. 100%.
Oh, there is?
Yeah.
Okay.
So I got a bottle of Jack Daniels underneath my desk. No, because it's like injecting, pudding into your joint, like it's that thick. I use a relatively large needle, but I freeze with a very skinny needle first. Okay, so it's not meant to be painful. I don't know, was it painful? I can't remember any pain. Yeah, so, yeah.
Is that the same as a cortisone shot?
No, so the cortisone is the steroid. So that's cortisone shots, the short-acting window. And so when people come or they've had a steroid shot or a cortisone shot, and they're like, oh my God, that shot lasted me a year. It was awesome. Well, what it was, you had the pain relief for 4 to 6 weeks, but during that 4 to 6 weeks, you started to move and you started to become stronger and use your joint properly. And then the effect of having that shot lasted the rest of the year until the muscles and the tissues started to weasel their way back.
Well, that's what I had, and it wasn't a big deal.
That's you use the small needles. So, the reality of the medical therapy, as I think I've said it a couple times, is that it helps a lot with symptomatic relief. Some of the medications like the PRP and the visco supplementation, they do help with some of the physiologic enhancement of improving the joint environment. But really, it's pain reduction and functional improvement that these medical therapies allow, which allows the patient to lose a little bit of weight, increase their strength and stability, and maintain their independence. And that's it. Thank you. So, yeah, fire away. I'm good for whatever. Terry, yeah.
When you talked about the meniscus surgery being
Yeah.
old surgery,
Yeah.
will that Vicos help somebody that has had that already?
So the visco supplementation injection, in order for it to work, you need to have cartilage cells that have the cells, they're called chondrocytes, that are going to make that slippery fluid. And the meniscus has those, but the cartilage has more of them. So will it work? Well, it depends on how bad the arthritis is. And as you go through the stages of arthritis, if you've got mild to moderate, the way I kind of relate to patients is the cartilage cells that make the slippery fluid are stunned. They're sleepy. And so this medication goes in, it stimulates them, wakes them up, says, oh, I got to make some more of the slippery fluid, and it goes making more of the slippery fluid. But the further along in the arthritic process, those cells die. And so you can't wake up dead stuff. And so the more viable cartilage cells you have, the more chance of success. And that's why it's more successful earlier on. The treatment improvement will be greater. The effect will last longer. If you've got stuff that the shot can work with.
And how do you find out if you still got that?
Well, we look at your x-rays and we see, okay, like how much, it's the subtle findings, is the bone more dense, like how much of the force is going through to the bone? What's the joint space like? How much of the compensatory changes to the joint have occurred? It tells me kind of what the joint health would be like without actually looking at the joint, in person.
Okay.
Yeah.
Tim.
I want to give first a shout out to your exercises.
Okay.
In that, a few years, about 5 or 6 years ago, I was part of a pilot study in Alberta about the GLAD program, GLAD, I think, from Norway.
Yep.
And that is exactly what you're talking about.
Yeah.
And I've been around the bend with all this, everything you've mentioned with Synvisc, and I found the cheaper one than Synvisc, and this is several years ago, did not work as well, but certainly it gave me wonderful mobility.
Yeah.
I think people should realize when they do these exercises, they're developing muscle memory if they ever need to get that operation.
Mm-hmm.
And if you ever have the operation, it seems to me one should say that the success of the operation depends on what you did prior to the prepare for it, and also the fact that the operation is 40% the surgeon and 60% the patient and how they handle the rehabilitation.
Yeah.
So I just wanted to say everything you've said is so, from my point of view, in my case, has really made me mobile. And I was bone on bone, you know, and still am bone on bone, which everybody thinks they need surgery the next day.
Yeah.
So I just want to say, for me, everything you've mentioned has been wonderful.
Right.
Now, I may feel horrible tomorrow, but right now, today, I feel 10 years younger than I am. So thank you for this presentation.
Oh, no problem. You know, and I didn't get a chance to say that, but you know, like in up to your question, you know, for us, surgery is the end point. You know, all these things help you live a life without having to go through the surgical process. Because surgery does leave you with slight reductions in your range of motion. You might not be able to get your knee to a full amount of extension. You might not be able to go all the way back to a full amount of flexion, you know, and whatever joint is affected. But, you know, exactly what you said is so true. Like the GLAD program has a lot of solid evidence behind it. I think it has its place in maintaining and developing strength for day-to-day activities. And you know, one of my projects that's on the boilerplate is to develop a pre-surgical strength and conditioning program for people that are going into surgery, where you come, and I've already had conversations with orthopedic surgeons in Aurelia and Barrie about this, is, you know, we're going to put you through strength and conditioning for 12 weeks before your surgery, because the research supports improved time to return to functional baseline, improved pain, if you go into a surgery strong. And if we can get you moving as soon as we can outside of the surgery, then you're going to get back to living life quicker and better, and to the full extent that you want to live. So all of these things try to avoid doing the surgery, but it's not forever. Like the medications and the shots and all that stuff will delay it as much as we can, but you know, surgery is there for a reason. And you know, you're doing exercises and you're walking, which is great because it's exercising and getting yourself ready for if and when you have to have your surgery. I hope you don't have to, but if you do, your body's ready for it.
So Dr. Trenholm, we're about 20 minutes over time.
Oh, okay.
People might need to leave, but if you're willing to stay up at the front, and people can go and ask questions a little bit afterwards. And those of you that need to go home, watch your shows, or go to sleep.
Yeah, get on the treadmill.
Get on the treadmill. Thank you very much.
No problem. Thank you.